Hello, my name is Dr. Andrew Gayardi, and I am very excited to be talking to you all today about our clinical research investigation into the use of ambulatory blood pressure monitoring by uniformed services family physicians. This clinical investigation looks at the diagnosis of an extremely important primary care topic, hypertension. Hypertension is one of the leading reasons why patients are seen by primary care clinicians across the world, and it affects 1/3 of US adults. Also called the silent killer, hypertension is a risk factor for cerebrovascular, cardiovascular, and renal disease. And this highlights the importance of an accurate diagnosis of this condition. There's a set of clinical guidelines for hypertension diagnosis that was published in 2015 in the Annals of Internal Medicine. This revealed that the office-based blood pressures frequently and consistently are both unreliable and poor prognosticators. There were significant discordance between the office-based blood pressures and the 24-hour blood pressure measurements, and it found that elevated ambulatory blood pressure was consistently and significantly associated with increased risk of cardiovascular events and mortality, and this was independent of their office-based blood pressures. The office-based blood pressure also is lacking due to the existence of this condition, white coat hypertension. This is where there's elevated office-based blood pressures with normal daytime blood pressures otherwise. And the CDC estimates that white coat hypertension has a 30% prevalence. Additionally, there's a 13% prevalence of masked hypertension, which is when an individual has elevated blood pressures at home, but normal blood pressures in the office. And while not endorsed by the AAFP, the ACC-AHA guidelines define hypertension as blood pressure greater than 130/80. This further highlights the importance of an accurate measurement in order to limit overdiagnosis. Additionally, the USPSTF is weighing in on this with an in-progress grade A recommendation for obtaining blood pressure measurements outside of the clinical setting to confirm diagnosis before starting treatment. So, what did we hope to accomplish with our study? Well, we wanted to identify the diagnostic practices of military family physicians for these conditions. We also wanted to assess the knowledge of hypertension guidelines and access to 24-hour ambulatory blood pressure monitoring, as well as the perceptions of barriers to the implementation of this 24-hour ABPM service. So our study was a cross-sectional survey as part of the IRB-approved Omnibus survey, which was conducted by the Clinical Investigations Committee by the Uniformed Services Academy of Family Physicians. Due to the COVID-19 pandemic, rather than have US AFP conference attendees participate, the survey was sent out to all registered US AFP members. Of the 2,559 successfully sent emails, 284 people responded for an 11.1% response rate. The data was then analyzed using descriptive statistics of the selected survey answers and chi-squared bivariate analysis comparing demographic groups. These respondent demographics were not significantly different than the overall AAFP population by gender or years since graduation. All right, so now on to the results, where I'm going to highlight the most interesting findings. Here attached, you can see a QR code, which you can scan in order to access our full survey questions, along with the survey answers, and the percent of respondents who selected each answer. For question 1, our survey found that 45.6% of respondents correctly identified an ambulatory method for confirming hypertension diagnosis. Question 2 found that 71.4% use an ambulatory method to diagnose white coat hypertension. Question 3 found that 35% relied on in-office blood pressures alone in order to diagnose hypertension. Question 4, assess the frequency of home blood pressure logs to diagnose hypertension. And we found that 45.7% utilize home blood pressure measurements a majority of the time. And then question 5 asks the same question, but for 24-hour ABPM. And this found that only 5% utilize ABPM a majority of the time. Question 6 asks if 24-hour ABPM was available, and 36% of respondents said that they do have ABPM available in their practice setting. And question 7 asked if 24-hour ambulatory blood pressure monitoring was available, would they use it to confirm a diagnosis of hypertension? And 75.6% said they would use ABPM if it were available. Question 8 asked about the greatest perceived barriers to implementation of ABPM services. And the most frequent responses were access to the equipment, which 41.6% selected, or logistics required to implement, which 38.4% selected. As you'll see in that survey from the QR code, there were a significant portion of respondents who omitted answers to certain questions. These omitted responses were not included in our data analysis or in the values provided previously. In our bivariate analysis, there were a few statistically significant findings, but overall, there were no remarkable demographic associations. So in discussion, these results demonstrated that the family physicians respondents frequently utilize office-based blood pressures alone for the diagnosis of both essential hypertension and white coat hypertension. However, the best available evidence has highlighted the importance of using ambulatory blood pressure measurements, whether home blood pressure logs or 24-hour ABPM, with the latter being the gold standard. This avoids overdiagnosis due to white coat hypertension and misdiagnosis due to masked hypertension. Additionally, 24-hour ambulatory blood pressure has the added value of providing an assessment of nighttime blood pressure. The Hygia chronotropy trial discovered that bedtime blood pressure dosing of at least one medication improved major cardiovascular events, and these findings confirm the results of the MAPEC trial. Physiologically, this is thought to occur due to the replication of the normal circadian dipping pattern, the absence of which is a strong prognostic factor for cardiovascular outcomes. And 24-hour ABPM is the only method by which one can identify these high-risk patients. The identified barriers to ABPM implementation included logistical support and access to the equipment. And part of the difficulty with access includes the cost of the service, which can range from around $1,250 to $1,500 for the device, software, and computer. The limitations to our study included the low response rate as we transitioned to a virtual medium, which raises the question of possible selection bias, though the demographics suggest a representative sample. This study also had the inherent limitations of a cross-sectional study. Future studies should evaluate the barriers to implementation of ABPM services further and should provide clinic-specific quality improvement investigations. In conclusion, this study found that a significant number of uniform services family physicians identified office-based blood pressures as adequate to diagnose hypertension, and clinical practices were found to align with these results. Additionally, while most do not have access to 24-hour ABPM, a majority would utilize it if available. Thank you very much. I look forward to any questions.